Okay. All right, we should be on air now. So welcome everybody, and thank you very much for joining today's research discussion. My name is Sebastian Potthoff, and I'm one of the directors of Open Digital Health. And so today it is my pleasure to introduce you to two fabulous speakers who I have worked with in the past on a European project, and I thought that they would be excellent to invite along for this research conversation. We have today with us Gentiana, who is a GP with experience in adolescents' mental health, suicide prevention, and health promotion. She is currently the head of health promotion department at the Institute of Public Health in Tirana, and also a full-time lecturer of health promotion at the Faculty of Medicine, University of Medicine, Tirana. And I also have the pleasure to introduce Andya, who is a clinical psychologist and a CBT therapist with over 10 years of experience in counseling, psychotherapy, and also who has been involved in a project assistant coordinator role in many projects for the WHO. And today, the two of them are going to talk to us about implementing for the first time an internet-based platform for treatment of depression in a low middle income country, the case of Albania. So we're going to start off with a presentation, and afterwards we'll have some time for questions and answers. But over to you two now.
Thank you very much, Sebastian. Hello, everybody. It's really nice to be in the middle of a group of colleagues, even though I don't know the majority of them, but I hope that we will have an interesting conversation. I will try to be clear shortly in order to have time also for discussion. First of all, I would like, okay. So just to make an explanation about the presentation, I will try to give a short overview of the mental health system in Albania, focused more in the services that are provided, and then my colleague Andya will continue with the presentation or introducing the digital mental health interventions conducted in Albania during these last years. Just one slide, something for my country. Albania is a small country, surrounded by sea, by Adriatic Sea and the Ionian Sea, part of the Mediterranean Sea, and also shares the landed borders with Montenegro, with Kosovo, North Macedonia, and Greece. The total population is less than 3 million of inhabitants, and we have an interesting story, two most important things that have had a great impact in our culture, but also in the mental health, are two facts. We have been for 500 years under the Ottoman Empire, and for, let's say, around 50 years under the communism regime. I would like to share with you these paintings from communism region area. This period had a great impact of our lives. I was born in 1974, in the middle of this period, and I remember very well many things regarding to this period. In this slide, you can see some paintings of socialist realism, which describe the work process of the new socialist man and woman working together. Selfless collectivism. This man, selfless new man, was willing to sacrifice his life for communism causes. He is healthy, with muscle, he is enthusiastic, happy, and he is ready to sacrifice his life. He is not driven by crude impulses. As in all other East European countries, also in Albania, the criminal law applied in conjunction with the system of diagnosis of mental illness. Together, they established a framework within which non-standard beliefs could easily be defined as a criminal offense and in this situation, substantially the basis for a psychiatric diagnosis. These photos are taken near the years 19, maybe 89, 19. We can let's have an overview of the system. The system, the mental health services and care was very much centralized. The treatment was symptom focused. Everything, the approach was only biological. Nobody talked about psychologist support. Also, the psychiatric hospitals served as intermittent sites for those who displayed anti-regime behaviors. You can see from these photos how they were treated, the patient, and how looks the hospitals, more like prisons. Of course, the 90s brought important changes in Albania. That was the fall of communism, but also the exodus of the population at the early 19th. The main part of the population wanted to leave Albania, to go in European countries for a better life, mainly in Italy, Greece, and Germany. But how was the mental health legacy? These photos describe, let's say, the situation, which was a tragic situation in which patients with mental health problems were in the early 19th. Of course, the fall of communism during the early 19th brought also some social-political changes. So the centralized economy was replaced by market-oriented ones. Health insurance replaced state-funded healthcare. But in the same time, we had some new adverse events. For example, the number of people with social economic difficulties was increased. The number of unemployment people was increased. And we had maybe sometimes also some new phenomena that like risky behaviors like drug abuse or HIV. We had the first case of HIV in 1993. But one of the most consequences was the brain draining, where many professionals leave Albania for a better life. The first decade after the communism system was called Big Gap Decade because we didn't have a law for mental health. The first law was approved in 1996, and this law tried to make some improvements, but it wasn't the perfect, of course. He aimed the law. In the law, it was aimed to reducing institutional care, to establishing forensic psychiatric practice, especially inclusion of non-medical professionals like psychologists, social workers, occupational therapists, etc. in the mental health workforce, of course. But the law did not touch upon human rights, and community mental health treatment for that moment was not a priority. The legislation was approved in 2012 when the mental health law was adopted, and in this time there were more defined the roles, responsibilities, competences of mental health professionals, standards and physical restraint specialized mental health services. There were specified also the documentation of involuntary treatment procedures. But anyway, even this law was partially implemented due to several causes. And the last adoption of the mental health law was made last year in 2021, and two were the main directions. strengthening human rights for persons with mental health disorders, addressing CPT recommendation. CPT is the International Committee for Preventing of Torture. And the second direction of the new amendment were related with strengthening mental health services for children and adolescents, which were a weak point in the previous legislation. Of course, after the communism system, after the first decade of these changes, there were a mental health reform conducted in Albania aimed in the institutionalization and decentralization of the services. So now you can see also from the figure how is decreased the number of beds in the hospitals and how is increased, we can see after, how is increased the number of visits in primary health care and the using of community mental health centers. Another important document, besides the others, is the Action Plan of Mental Health. For the first time, also was signed in 2013 with 10 years duration, and now we are part of, together with Andia, we are part of a working group that is working for the new Action Plan of Mental Health. What is new this time is more actions, more plans for young people, for children, adolescents, and young people. We still have difficulties with funding. You can see the figures about the funding in health in general, but especially the percentage of the funding for mental health problems, and where the majority of funds goes still to the hospitals. Another difficulties or another concern for us is the mental health workforce in Albania. You can see here, these are all data, but these data aren't improved even now. We have a very low rate of psychiatrists, for inhabitants of psychiatrists, nurses, psychologists, and social workers that work in mental health services. Another concern is stigma. In Albania, stigma for people that have mental health problems or disorders is high. You can see here some results from a national survey on public perception of mental health, when we can see that these figures are very high for people with these problems. But on the other side, there is a good sign for better utilization of the health facilities. So these are some figures that demonstrate this fact. So if you compare with 2006, of course, the number of visits it's increased to the primary health care for mental diseases, but of course this is not what we really want. If we compare this data according to the age group, we can see that the number of young people that use these facilities is very low due to the stigma. Very shortly, some figures about or facts about different surveys that we have conducted. Of course, in Albania, we have conducted different population-based survey focused on young people, on children, on general population, and also in elder people. If we see some results in Albania Demographic Health Survey conducted 4 years ago, we can see that only 2% of the population, 15 to 49%, has accepted to be diagnosed for depression, which is a very low figure, and by our estimation, this figure might be at least 5 times higher. This situation demonstrates a low utilization rate of health services, most probably regarded or influenced by high stigma about this condition. According to this study, the prevalence of reported depression among individuals of this age group was substantially higher among poorest and lowest education, which points significant inequity issues of mental health problems in the Albanian adult population. Regarding the suicide, the risk for in general population, the risk is, let's say, higher among males. There is no difference observed among young people. Contrary to the beliefs, there are even more suicide among teenage girls compared to teenage boys. The risk of dying from suicide has remained stable during these last years. And an increasing trend is observed only at males over 25 years old. An increasing trend observed among adults, it is not reflected also in the young people. Which are the main stakeholders in mental health service system in Albania? Here are, I try to put the main stakeholders because of course there are more than them, but the main and most important institutions are related with mental health are in this slide. I will try to make just a short description for the main part of these services. First is the primary healthcare services, family doctors or GPs. According to the law for mental health within the network, this service for mental health is included to care, is included the care provided by family doctors at primary health care, reflecting the changes compared with the previous period. The role of the primary healthcare service in the field of mental health is then clearly specified in the essential package that we have approved by Minister of Health in 2015. All psychiatric categories of illness are supposed to be taken care at this level, and only for important or difficult cases, these cases are referred to specialist or specialized services. On the other side, since 2015, in Albania has started a national checkup program, which include also early detection of management of depression in community. But what we see is the fact that very few people use this opportunity when make the checkup compared with other tests or analysis that are provided during the checkup program. This is another argument that stigma is high for this problem in Albania. On the other side, we had a new strategy for primary health care in Albania, which foreseen to provide during these 2 years 10 centers which will be piloted and will serve as model of center of family medicine, which will include not only the general healthcare but also social support. Until now, these centers aren't ready, but according to the Ministry of Health, they will be ready during the last 2 years. The second part of the services are specialized outpatient services. These are operating in the polyclinics in Tirana, which is the capital city, or in the premises of regional hospitals in the other cities. Community-based mental health centers are another, let's say, service available in Tirana. These are provided since 20 years before, and year after year, the number of these community-based mental health centers is increased. What is interesting, or of course, like in other countries, these centers in compared with family doctors, of course, has a multidisciplinary group of professionals in which there were psychiatrists, psychologists, social workers, occupational therapists, etc. And these centers cover, let's say, more than 70% of the population. The other part of the population, it is covered by neuropsychiatric cabinets in the regions. The focus of these community-based mental health centers is mainly more in the serious mental health problems that cannot be treated in the primary health care. On the other hand, these centers are very much interested to make screening, community screening, but they cannot make this duty due to their burden of work and limited resources, especially in community nurses. Another service are supported homes. We have in Albania 14 supporting homes spread in the main cities of Albania, which provide residential care for people with chronic mental disorders in a setting which is closer to the family, where the goal is the care and rehabilitation of these persons. Then we have hospitals. We have 4 psychiatric hospitals in Albania. 2 are for acute episodes, one in the University Center in Tirana and the other in Shkodra, and 2 other specialized hospitals mainly for chronic patients. As I presented before, we can see the trend of reduction in beds, except Elbasan. It is one of the concern also for the Ministry of Health, is the number of patients that are here. It is remain the same, and these are chronic patients that are here in this hospital for more than 5 years. And lastly, I just wanted to mention something for psychological support services in the school settings. Since 2006, in high schools of Albania, we have started to provide psychological support, counseling services, which aims to provide professional mental health support for students, addressing mental health problems at the school, assessing cases of children with special psychosocial needs, etc. In 2020, this service was reorganized and the number of staff was doubled. Now these are the figures that we have for this year, academic year, and the Ministry of Education has planned to increase more the number of this psychosocial staff in the school. And lastly, just to say something about online interventions and platforms, before Ima Project, for which Andrea will discuss later, we had only 2 only 2 platforms. Nukia Vetam, you are not alone, it's the translation, which is a counseling line for adolescents and young people, and Alo 116, it is also an online counseling platform for abused and neglected children. Now I'm continuing with Andrea. Andrea, are you ready?
Yes, you can you hear me?
Yes.
Okay, thank you, Genta. Well, first, I would like to thank both Sebastian and Genta for inviting me to present this first time in Albania digital mental health intervention. So, as I was talking with Sebastian, this experience has been a pioneer project and work for not just for me and Genta, but for Albania as well. So me coming from a clinical background and Genta coming from an academic background, we joined our forces in order to try to implement a new intervention in the country. So how this started, just saying in a few words, we were contacted by an Albanian, let's say, professor, and now she's a professor assistant called Arlinda Cerga, Dr. Arlinda Cerga. She works as a professor at the London School of Hygiene and Tropical Medicine. So she contacted us in Albania and a psychiatrist in Kosovo as well to introduce us this unique opportunity for Albania and Kosovo, being low and middle income countries, to join forces with other countries in Europe and Australia. So this is how it started. We became part of the Implement All project, which was a project funded by EU, and it started in 2017 and it continued till mid-March 2021. So before that, we had no specific intervention, particularly evidence-based psychotherapy intervention, being part of the mental health services that Genta described. This kind of services are only provided privately, in private practice, so a very limited number of people can afford to actually let's say, profit from this kind of services. So for us, it was a double challenge, meaning that we need to introduce cognitive behavioral therapy, and in this case, a program, an online program for in the existing services. So we discussed among us and experts, so would be the more feasible services that we could, let's say, recruit. And we discussed also with the Minister of Health, which was very, let's say, crucial in this, in the initial process, but also during the whole implementation phases. So we decided that the community mental health treatment centers were the most feasible and to implement the digital mental health intervention within the Ima project. How can I don't think I can move this.
Yeah,
how can I move the slides?
You can share your presentation because you are host.
Yeah, but I cannot move the slides. It's not working.
So but you have to share. Okay.
I think, Gentiana, maybe you must stop sharing first. Yep, here we go. And now Andrea should be able to share hers.
So I can continue. So once we identified the treatment, the services that would implement the online platform.
And just to say, we don't see any slides.
Yes, I don't see slides either, but I was thinking maybe to continue.
Okay,
Andrea, you can come here, Andrea, because.
Okay, maybe you can just, I will say next, Genta, and then you can just,
but
if you would be kind to.
Yes.
Okay, so yes, so once we identified the 3 community treatment services that would cover, let's say, 80% of the population. So this services was one community mental health treatment service, one of the 3 in Tirana, the capital of Albania. I just want to remind that almost 1 million inhabitants live in Tirana, and these 1 million inhabitants are covered by 3 community mental health treatment services. So we selected one of the 3 in Tirana, and then we enrolled and invited one in the north part of Albania, in Shkodra, and the 3rd one in the southeast of Albania, in Korça. So this also will explain how these services actually had the triple rate of coverage, geographical coverage of the population. So in Tirana, for example, the limit rate is around 150,000. I mean, geographically, why currently the staff there, which is let's say let's say there's a very limited number of staff, they cover the triple, that meaning more than 300,000 population in the city alone and surrounding the city, of course. So one of the initial objectives for us was to implement a mental health intervention for depression, meaning that it was the first time that we are implementing a digital intervention at community mental health treatment centers as a standalone, meaning that the patient would be invited to use it if they would prefer to do that, and as a blended treatment, meaning that we would this would be an integrated part of the counseling that the psychologists in the treatment centers were already providing. To train the mental health staff on cognitive behavioral intervention, train the GPs, the general practitioners, how to diagnose and refer patients for suffering from depression, and to train staff on delivering a blended internet-based CBT. And also to reach the hard-to-reach population, meaning that 80–90% treatment gap, which was, of course, related to stigma, as Genta previously mentioned, by the demographic health survey, that only 2% of people actually were diagnosed with depression, meaning a very low number due to stigma as one of the reasons. Genta, next. So this was our initial objectives. We are also looking at what could be some, foreseeing some challenges, meaning that the community mental health treatment services usually and mainly provide care mainly for severe mental health problems, such as psychosis and depression and other disorders. Meaning that this would lead to increased stigma for people. We were reaching and we were wanting to enroll people with mild and moderate depression. So this was our aim, to increase this number, to seek and treatment in the community mental health treatment centers, and then we could like enroll in for them to use the ICBT. So the clinical psychologists were not trained in CBT, so they didn't have any education on basic CBT, how to provide CBT, the foundation of CBT, and then on how to use the platform per se, meaning how to register patients, how to recruit them, how to monitor and then motivate patients to use the platform. Psychiatrists in Albania, due to the fact that psychology and social work is a new profession in the country. So the first university of social science was established in the beginning of 2000. So I'm one of the second generation of psychologists coming from the university as a psychologist, clinical psychologist, meaning with no specific training in how to provide counseling and intervention in community mental health treatment services. So we also needed to address that. And so psychiatrists in this regard felt a little bit threatened, and initially, and still are, even though they do not verbalize it, threatened by the new kind of intervention as psychology and CBT. So clinical supervision is still non-existent in the country, unfortunately. So this is something that was a huge gap, which interfered with the quality of the treatment services. And so we were trying initially to address that as well while we were implementing the project. Another thing that we observed and identified was that the new model of working that we were introducing. So as I said, this was a double challenge, because we're not just introducing a new treatment method, but also a new modality, meaning CBT, and then also an online intervention, which initially was felt as threatening also for the psychologist, and as a say, like a workload burden as well for them initially, when we had some group that I will talk about, we conducted some focus group discussion with them. And technology in Albania, it has the highest coverage in internet, meaning that more than 90% of the population has access to internet. And that's an advantage for us in order to implement this project. And the training would be provided by us within in the framework of this project. And the results of the project then would be informed to policymakers in order to be included in the strategy and mental health legislation. Next. So, as I said, what we once it was, let's say, agreed upon what kind of mental health tool we were going to use. In this regard, it was I Fight Depression, which is developed by the European Alliance Against Depression. So we decided to use this tool. So we translated both the website content and also the tool, the I Fight Depression tool content. So the website is in public domain, meaning that anyone can have access, and it's basically getting information about depression and treatment for both adolescents, youth, and adults. While the I Fight Depression tool, it's accessed only by people who can, let's say, by patients in this regard. So also the process of translating and language adaptation, because we had to make language adaptation for both the Albanian population living in Albania and the Albanian population living in Kosovo. So this took almost a year for us, and then we had all the content we have to put out there ourselves. So this was for us, for both me, Genta, and for our colleagues in Kosovo. This was learning new skills for us as well, but also interesting experience. Nevertheless, it took us more than we thought initially. So once we had the platform ready, we launched it in July 2018, I guess. We launched both the website and the IFI toolkits. We already had identified the 3 community-based mental health services, and the total number of initial staff that we recruited, meaning psychiatrists, nurses, psychologists, social workers, and occupational therapists, was 25, with the respective professionals: 3 psychiatrists, 2 child psychiatrists, 6 psychologists, 5 social workers, and supporting staff, 1 psychiatrist and 7 nurses. During this initial phase of recruitment, we had 3 dropouts, and then we had some people during the staff in the last 2 or 3 years of the implementation phases. We also had a change of the staff that we were going to discuss. So in the first thing, as one of our objective was to not only introduce the platform, meaning that we conducted initially, we had to present what the ICBT, the I Fight Depression tool first. So they had to look, the therapists and all the staff of the community mental health treatment centers wanted to understand what is digital-based mental health intervention. For example, I never heard about there was any digital mental health intervention before this project. So this is a new, still is considered a new intervention and idea that many professionals don't know about. And CBT, of course, is also a new thing. Many, even psychologists or psychiatrists, are not knowledge about evidence-based practices. Besides psychodynamic, CBT, cognitive behavior therapy, is still unknown in many professions related to mental health. and in general population as well. So we conducted the first training in CBT, where we invited all the staff that were from the 3 community treatment centers. We, during the initial phase, but also during the implementation, the treatment as usual, we call it, treatment as usual, meaning that the staff was using the platform, they were registering new patients, they were following up with the patient, how they were interacting with the platform before the Ima trial phase, the ITFIT toolkits. So during this period, we had to, because it was a new intervention, we had to conduct a lot of routine visits in all our 3 sites, and doing workshop and refreshing the knowledges about CBT and ICBT. Next. This is one of the pictures about them filling out the questionnaire of ITFIT toolkits as well, because we had to translate them and collect some basic data. Next. So one of, as Genta mentioned, one of the objectives besides conducting trainings for both our community treatment centers, which were involved in the project, but also with GPs, was raising awareness about the platform specifically, and also about mental health services, the community mental health services. So people, more and more people could access these services and the platform in this case. So we used the opportunities we got, like conducting the AAD meeting in Tirana in December 2018. We see here the director of EAD. And with the participation, we had a really excellent partnership, not only with the Ministry of Health of Albania, but the Faculty of Medicine, and other stakeholders. Next. So in order to make the ICBT more visible to the population, we did a lot of interviews, TV coverage. So this one is a picture of the EED meeting, where Arlinda, one of our partners, is talking about the platform in one of the main national TV channels. And Genta here was invited in a very popular TV show in the morning, talking about, of course, the meeting, but the aim of the meeting was, of course, to introduce the platform to the public. Next. So, as I said, we used any opportunity, like World Mental Health Day, for every of the project implementation year, meaning 2018, 2019, 20, and so on. Next. Next. So for us, we understood that for us it was very important in order to understand how to engage the practitioners who were directly involved with registering the patient and follow up with the patient for the implementation of I-5 depression tool, was to engage them as much as possible. So for them to have a sense of ownership of this new intervention that we're conducting. So we understood that having a sense of ownership from the therapists themselves, who were directly engaged with implementation of I-5 depression tool, was something that was motivating them to be more active and engage with the patients. So this is one of the activities where we presented the project and some initial intervention about the ICBT, how it was, and that was one of the therapists from one of the community treatment centers who was presenting in one of the international conference at the Faculty of Social Science. And this is the same person, one of the therapists, presenting this new intervention at the International Albanian League of Psychiatrists, which is one of the biggest network of Albanian psychiatrists from all the region, presenting this to this big platform of professionals. So, as I said, for us it was very important to to raise awareness, because raising awareness was a problem. Stigma was very, very high, and we needed to reach as much as possible, particularly related to COVID outbreak. And I will talk a little bit about this briefly. So what happens is that next Genta, so we use any platform, anything. So what happened is that in November 2019, we had a really major earthquake in the center, in the Adriatic Sea, close to Durrës, which is very close to Tirana. And 1/3 of the let's say the geographic of Albania, of the country, was impacted, severely impacted. We had more than 60 fatalities and thousands of people injured, but we have thousands of buildings either destroyed or severely damaged. And one of the buildings that were severely damaged was one of their community treatment center in Tirana that was implementing that was part of the project, Ima Project. So they had immediately, even before the earthquake, maybe I forgot to mention that even before the earthquake, and when we recruited the staff, we noticed that the community, generally community mental health treatment centers in Albania, the buildings, the infrastructure is really, let's say, old. And so this was one of the challenges. For example, the psychologists didn't have a counseling room. Either they didn't have, or 3 psychologists were staying in the same office, let's say. So they had like take turns in order to follow up with patient and provide counseling. So this was one of the challenges. So what happens is that because of the earthquake, one of our treatment center had to halt the intervention, because they had to be evacuated by that building, the previous building, which was severely damaged, and then they were provisionally staying in another building which was quite very old, and it was not appropriate for community treatment mental health services. So this whole phase of moving from one place to another took almost 7 to 8 months for the staff, which demotivated them quite a lot due to this, and it impacted our project as well, and the uptake of new patients for registering them, and then let's say implementing the digital mental health treatment center. We also noticed something. Yeah.
Excuse me, Anya. Just I didn't want to interrupt.
We are finishing. Yeah. Sorry. Okay.
Just because we almost don't have time for any questions otherwise.
Okay. So Genta, go. So this training, continue. So because of what we noticed as because of the lockdown period, so we needed to take immediate steps, meaning that we use this opportunity to have more media coverage and be more visible in the media all the time. Genta, Linda were very, very much active during the first 2-3 months of the lockdown period. As new people were contacting the community mental health treatment centers for anxiety problems related to lockdown. So we took an opportunity to provide direct access to the patients just by giving us an email address, and then we would immediately register them for them to use the platform. So we saw an increase of people being registered and using the platform during the lockdown period. Next, Kenta, compared to the previous year. Next. Yes, you can see there is an increase during the lockdown period compared to the previous year. Okay, next. So despite the fact that we had, let's say, 179, these are the data from mid to 2020. So we had 180 or almost 200 and something people totally registered. The number of dropouts was like 90% or more. So that means we were every 3 months we were reporting on the number of uptakes. So patients were registered and then looking at how much they would engage with the platform and using it. So we see a very high a percentage of people that were dropouting from the usage of platform. For that matter, so we decided to also in the framework of IFI toolkits. So we were trying to see how to motivate and interact with the staff in order for them to integrate this new intervention, the ICBT, in their daily practices. So doing trainings, doing workshops with GPs in order to increase the number of new referred patients, and so on and so forth. So next. So one of the okay, next. As I mentioned, there was a couple of challenges we had. I mean, beside the earthquake and the COVID, I also mentioned that the staff, even though the staff was very interested in participating in trainings, so being trained, learning about CBT, and looking at it, this intervention as something valuable for increasing the number of people, but also for the fact that it was online, reaching people who were remotely, let's say. There was many challenges regarding about, they would see it, the fact that most of the staff would, let's say, take care of severe mental health problems in the service. So this was one of the challenges. They would say that, okay, but we cannot really implement this program for our patients because of the stigma. People with mild and moderate depression are not coming to our services so they can have access to this platform. And GPs, on the other hand, for example, they didn't have the tools or the means or the knowledge to identify early and moderate depression in order to refer to the patient. This is for many reasons. This was not only due to the lack of knowledge, but as Genda said, because the Albanian population, the use of health services by the Albanian population is very, very low. So one of the problems is how to increase the service usage by the population, particularly related to people who are young adolescents and youth. So this is one of the main challenges, national challenges. So how to increase the usability of health services in the country, not just related particularly to mental health, but all the services. Next, so we also did a research for Albania and for Kosovo. It was a qualitative assessment of the organizational readiness of the services, 6 services, meaning 3 and plus 4 from Kosovo. We conducted 6 focus groups discussions, semi-structured focus group discussions, and then we analyzed that in the framework of the organizational readiness model. That is, so we see it in 2, let's say, aspects. One is the change efficacy, and the other one is the change commitment. So the change efficacy was how much.
And yeah, sorry to interrupt.
Okay.
I'm just wondering, because we only have 5 minutes left, and I'm sure some people might have some questions for you.
Yeah.
And then in terms of the papers, we can easily share them after the event. So is that okay with you if we ask for a couple of questions? Yes. Sorry about that. So yeah, thank you very much for the really comprehensive overview of implementation of digital health in Albania. Really interesting. Also, like, to see the whole historical background to it. It really sort of like helped contextualizing everything. So at this point, I think we'll see if we have a couple of quick questions for the two of you. So we have one coming from Frida here. Were there any differences and challenges in implementing the tool between settings, community and acute setting? You mentioned organizational readiness. So yeah, maybe that opens it up a little bit for you to perhaps say a couple more words about that, if you like.
Well, Ginda, do you want to answer to that? First, I want to understand as we defined community and acute, as we said, people with acute or mild or moderate mental health issues due to stigma do not seek help. So this was one of the main challenges for us. So how to how to make accessible for people who would not seek treatment, beside the ones severely with mental health issues, that would of course be part of the treatment system, and specifically the community treatment service system. So how we could acute, that's why we conducted workshops and training with GPs in order to increase their knowledge, to refer, to identify people with acute treatment, if I understood the question correctly, and Geta maybe can add a little bit. In regard to organizational readiness, I didn't include the results from the Ima. So there is, I only thought that we could present the challenges and the process that we from Albania, and as a local, let's say, partner, we faced during this period of time. So the results of the Ima project, you have it it is already published. The results here is in regard to the focus group we conducted prior to the implementation of the project. So we want to see how ready and what were the perception and the beliefs of the staff in regard to the implementation prior to the implementation of the project. So these the results of that article, qualitative article, is reflected here in this presentation, meaning like they would see this new intervention as an added value to what they were doing, and particularly reaching people who didn't have access to the services due to stigma or distance. And but as I said, one of the barriers, challenges that was identified by the staff prior was the fact that they were overloaded with work and with patients with severe psychiatric issues and severe depression.
That sounds good. Thank you. And if you have any papers or results, again, we can totally share them after the presentation.
Yeah.
Perhaps, so thanks also Frida for the question. Maybe we have time for one more question, if anybody has one. Oh, here we have one from Aminul. Aminul is asking, how do you identify the mental health patient and connect with iFight depression tool to intervene patients? So I suppose to refer them to the service.
That's a great question, actually. It's a really good question. Yes, this is one of the initial question that we had when we were not just identifying the treatment services, but how, which were the patient. Actually, I think it was a question, it's also in the IMA partner meeting. So what are the let's say, the inclusion criteria for selecting patients that would profit from the iFight depression tool? So one of them, as I mentioned here, would be a patient with a mild and moderate depression, with no comorbidities, psychiatric comorbidities, substance use comorbidities. Because the platform provides both treatment for patients, for youth and adults from 15 years old and up. Also age was one of the for 15 and up was another inclusive criteria for that. But as I mentioned,
from the sites when the implementation was occurring.
Yes. And in regard to the effectiveness of the platform, it was discussed that the iFight depression tool has the youth version has 7 modules, while the adult has 6 modules. So the idea was we would say that if a patient would use 2 to 3 modules, let's say, topics, that would be considered as an intervention %. While if they would use 1 or less, that would be considered a dropout or not use of the platform.
Thank you very much. Unfortunately, we're running out of time, but it's really, really good to have you present today. really interesting, and again, like really pioneering this type of implementation work in Albania. So, you know, this is a very different from the kind of presentations we usually get. So seeing all of those challenges and how you have like managed to overcome them, I think it's a really impressive example, you know, where there's no infrastructure at all, and really pushing the idea of digital interventions besides the stigma, and having the media present, and kind of making sure that this is becoming normalized in Albania. I think this is really fantastic work. So I would like to thank you again for this presentation, and thank you very much for everybody for attending today. So thank you everyone, and
thank you very much.
Look out for further invitations to these events, and really everybody's welcome to come along.
Thank you.
Thank you.
Bye. Thank you.
Thank you, Gentiana and Andia.
Thank you,
very
Sebastian.
much.
Thank you.
Very good to see you.
Yeah, me too.
We hope
Likewise.
to see you.
And hopefully see you soon again
Yeah.
for some other project. Who knows?
Yeah. Good luck, Sebastian, with your new role. Good luck.
Thank you very much.
Bye.
Okay. Bye-bye.
Bye-bye.